Thank you. And Brian's been a tremendous source of help for us, not just in terms of the HRB and data and information, but also in terms of securing and sourcing speakers from an EU perspective and from other countries and administrations. And also, Brian, that was a very helpful slide at the end, just in terms of your thoughts about what might help us in terms of an Irish model and an Irish model of research. So thank you for that. Okay, next up, and he is at the podium already, is Dr. Peter Kelly, Assistant Professor of Mental Health Nursing, Trinity College Dublin, who also sits on the National Oversight Committee that Jim would have outlined. Very welcome, Peter, in 7 minutes.
Thank you very much. Good morning, ladies and gentlemen, members of the Assembly. It's an honour to have been asked to present to you this morning. I've worked just under 20 years in addiction treatment services, and I've spent about 10 years as a researcher and academic, so I'll just give you a brief idea of my background. Ladies and gentlemen, I'd like to ask you to visualise a scenario in the year 2035, the next national drug strategy, into which many of the recommendations from this Assembly have been integrated, has run its course. Picture a service user walking into a treatment service. The service user is happy with the treatment service and feels respected. The buildings are comfortable, they're inviting. This person has a care plan. The care plan is written collaboratively in conjunction with their key worker. This person has timely access to a choice and range of treatments, social supports, therapy, detox, rehabilitation and employment opportunities. This individual has absolute confidence in the complaints process. They live in a hostel with lots of other drug users and tell 5 or 6 other people how good that treatment service is, bringing more people into the treatment service. And this experience is replicated throughout treatment services across the country. The staff member who warmly greets this individual is happy with their workplace. They feel respected, they're well educated, and they feel competent. They have access to ongoing training, supervision, and support. They have a career pathway and job security that is equal to or better than other healthcare workers. They work in a multidisciplinary team that communicates well and works collaboratively, has a flat hierarchy. The service is well resourced and has good governance, regular audits, and is subject to independent inspection. The service is person-focused, supports human rights, and follows best practice. This staff member is particularly proud to work in this service. But how did we get there? Firstly, we listened to the best available research which informed us that service users who access well-run and well-resourced services where happy, healthy and educated staff work are far more likely to accomplish better health outcomes. Think of this interaction between the service user and services as being at the interface between policy and practice. It is at this interface between policy and practice where many of the recommendations from this Assembly will be experienced in real life by staff and service users in 10 years' time. But how might the Assembly influence this interaction? Firstly, and I'm glad Brian mentioned the ecosystem, firstly, it might help to consider the environment in which the workforce operates like an ecosystem. So if we use the analogy of a farmer, in order to have a successful crop, a good farmer, before planting a seed, needs to consider many aspects of this ecosystem: the type of seed, the soil composition, the weather, the time of year, etc., or else the seed will not grow. All too often, and the evidence tells us this, in healthcare services, including in addiction treatment, research can find us the best seeds, the best treatments, and worthy concepts. But when we try to make them grow, we give very little consideration to the ecosystem and whether this system has the capacity to support this growth. In this context, think about the seeds we are trying to grow as areas like recovery-orientated services, trauma-informed care, human rights-orientated treatment, case management. None of these will flourish unless the ecosystem has the capacity to support them. This slide, and due to time allowances, I won't go through all of the different areas of it, but this slide gives you an idea of the different levels and domains that make up the ecosystem that contribute to this happy face in the middle, which is either a staff member and a service user rather. These are the areas of the ecosystem that need to be targeted in the next strategy. But it is not that we need to target them, it is how we target them that is important. All of these component parts, though not exhaustive, are referred to in the literature of components as an effective workforce development strategy. But how did we create this treatment system in 2023? What types of recommendations were in our next policy, and how did we implement them? So we have strong service user involvement at all levels. Service users are front and centre of every decision we make. You can call that a value or an objective. The National Drug Strategy is characterised by specific, quantifiable and measurable key performance indicators for the services as well as the strategy.
Just 2 minutes, Peter.
We have fully independent oversight of the implementation of policy, so those providing oversight should not be in any way dependent on the Department of Health or the HSE for funding. An independent inspectorate for all drug services, for example, HIQA. We need full accountability for all expenditure on treatment. This would likely need a change to the current funding model. A national mapping of the staffing skill mix and resource allocation of all services onto population need, population density, deprivation index, population projections and demographics. A treatment delivery model developed from this mapping should be rolled out nationally with stipulated provisions for population profiles built in. We need to collaborate with educational providers and researchers in order to educate the workforce over a long period of time. Again, we need a universal IT system, something which is proposed under Sláinte Care, with a unique patient identifier. All of the above is likely to require reform of the current structures, drug task forces, more standardisation of how services are delivered, and greater centralisation, which may involve loss of autonomy for some service providers. But this is absolutely necessary.
Just less than a minute. Yeah, thanks.
In conclusion, and this is evidence-based, it's based on my own review of the evidence over the last 6 years, my suggestion is to develop a comprehensive national workforce development, service development strategy for drug treatment. This should be a priority of the government, Department of Health and the HSE, and should be developed in conjunction with Sláinte Care. At the core of this strategy must be full accountability and transparency. Ladies and gentlemen, thank you very much. Cheers.